I'd just started my round of golf, and I was walking up to my golf ball afterwards, and my chest was getting more and more painful. And then I suddenly started getting aches in my jaw, and I knew that meant that I'd got to stop and get back to the clubhouse.
I was about 2.5 miles from my workplace, and all of a sudden I felt this pain just below the sternum, and I didn't think nothing of it because I was chewing peanuts. I thought it was getting that's what it felt like when you get things in your throat and you go for it. And you know, as I drove further, I just got in a real big ball of sweat. I thought, to hell with it, I've got to make sure I get to a safe place where I can park. And straight away called the ambulance.
Heart attacks occur when an artery blocks off and the heart muscle is deprived of oxygen, and the quicker we can get that artery open again, the less damage there's going to be to that heart muscle. So primary angioplasty is the procedure we use to treat the highest risk heart attacks. Treatment in the UK has changed a lot over the last decade. We've moved from treating all patients with clot-busting drugs that are injected to now offering everybody primary angioplasty because we know that patients are more likely to survive, they're more likely to survive without disability. The most important thing that we can do in providing this treatment for patients, beyond making sure that we do the technical parts of the procedure to the highest possible standard, is to make sure that it happens very, very quickly. So we work very hard here at the Royal Berks with every person involved in the team to make sure that we do everything as quickly as possible, that there aren't any unnecessary delays in the process. And we have worked hard at that, and we've consistently improved year on year and shown that we can deliver heart attack treatment more quickly than anywhere else in the country.
So if we receive a 999 call for presumed cardiac chest pain, we'll attend the patient. The first thing that we need to do for the patient is to get them assessed very quickly. So we'll assess the type of pain, when it came on and what they were doing, and we'll also be monitoring them using our observation tools that we have. The main tool we have for assessment in cardiac chest pain is an ECG. So we'll do a full 12-lead ECG on the patient, and that will give us an indicator of whether that is cardiac related or not. Sometimes it can be completely normal but still cardiac related. Everybody is different, so it's looking at other risk factors as well and how well the patient is or isn't. If we are going to move the patient, as with most chest pain we will get them onto the ambulance as quickly as possible, administer certain drugs. So we'll start with aspirin, a spray called glyceryl trinitrate, which we administer orally. Some of those can be quite diagnostic in use as well, because if the pain reduces, it can be an indicator that it's cardiac in origin. We also, if we are absolutely concerned that it is definitely a heart attack, we can get things moving very quickly. So we don't go to A&E, we come straight to the cardiac care unit. Sometimes if it's very late at night or very early in the morning, the cath lab team will need to be raised and reached and basically mobilised to the cath lab. So the time for the patient between leaving home and getting into cath lab and having very quick reversible treatment is very, very short. And that's one of the great things that we have, is that we can do that very, very quickly with a pre-alert process that alerts everybody to the fact that there is a serious case coming. On arrival, the patient will be very anxious and probably quite concerned, so one of the primary things for us is reassurance and explaining what's going to happen and where we're going. So we'll go straight through the cardiac care unit, we'll be met by the team at the door, we'll explain and give them a handover of everything that we've done, what we suspect, patient's history and any other risk factors, whether they're diabetic or they've got a cardiac history or familial cardiac history. And then we'll transfer the patient to the team's bed in the cath lab.
Okay.
No cardiac history. ECG shows quite extensive ST elevation.
Okay.
So there'll be 2 nurses in the cath lab. One of them will be scrubbed and assisting the cardiologist with the procedure, and one of them will be a runner nurse who will be grabbing various bits of equipment and passing them on to the team, giving medicines to the patient, making sure that the patient is comfortable, giving them analgesia as required. There's a radiographer who drives the X-ray machine and manoeuvres the table so that we can get the best possible pictures we need to undertake the procedure. And there's a cardiac physiologist who has a number of roles, but most importantly, they're monitoring the patient very carefully, monitoring their heart rhythm, their blood pressure, and assisting us with various measurements so that we can keep the patient safe and we can react quickly if problems arise. So the patient is usually awake and not anaesthetised for this. They'll have some local anaesthetic, but they won't be anaesthetised. Just occasionally, if the patient has had a cardiac arrest as part of their heart attack, they may be anaesthetised and ventilated, but they're usually awake and talking to us, and we want their feedback. We want to know whether they've still got a lot of pain, because we can treat that, and sometimes we may need other information from them. We're collecting information all the time whilst we're undertaking the procedure. We perform primary angioplasty using a fine tube which we insert usually into the patient, an artery at the patient's wrist, and we thread that up to the heart, and we're able to squirt X-ray dye down the heart arteries and see exactly what's happening and where the problem is. Once we've identified the problem, we'll then thread a very fine wire all the way up the tube, down the occluded artery, and that gives us control of that diseased artery. And we can then thread further equipment up and down the wire, firstly a balloon to stretch the artery open again, and then stents, which are metal mesh tubes, which we'll place within the artery at the point where it had been occluded, and inflate that metal tube on a balloon so that it's left behind to hold the artery open forever. We also use quite powerful medicines to thin the blood and stop it forming further clots within the artery, and all of that is critically important to making sure you keep that artery open and stop the heart attack in its tracks. So this still image on the right is the first picture that we have taken, where the patient comes in the middle of their heart attack, and we show that the artery is blocked halfway through its course. And the picture on the left shows the artery reopened after the primary angioplasty, which would hopefully have taken place within a small number of minutes, and immediately results in their pain settling and their ECG normalising and the heart attack effectively being over.
I was walking on the golf tee at 11:15, and I know that I was in here at less than 2 hours later. So, you know, it all went very quickly, but I couldn't be exact on any of that because I wasn't really with it for a lot of the time.
At the end of the procedure, the patient is transferred directly from the catheter lab around the corner to the cardiac care unit, where there's a team of expert nurses waiting to receive them, and they will then continue their care. The first few hours we're watching things very, very carefully to make sure that the heart attack has properly settled. And then over the next 48 hours, just making sure that their recovery follows the normal patterns, that we're able to start the right medicines, get them up and walking about, making sure that they've got all the right information they need. Most patients will be discharged home after 48 hours, which again is something that people wouldn't have believed 20 or 30 years ago when we had so little to offer patients suffering heart attacks.
The outcome for patients is extremely good, and I've been fortunate enough to witness quite a few heart attacks that have been reversed or treated very, very quickly in a very short space of time.
So there's a government target to try and get 75% of patients treated within 150 minutes of call for help, but across our region we've been more ambitious than that, and we've worked very hard to try and treat as many patients as possible within 120 minutes. We know that if patients slip beyond that initial 2-hour window, their chances of surviving start to fall significantly. We've managed consistently to treat more than 90% of patients within 2 hours. against a national average of somewhere between 50 and 60% of patients. So things are working very well across our region, and that's due to really, really tight team working.
The patient journey is paramount. I meet with Royal Berkshire team on a monthly basis to review all the previous month's primary cases that we bring into the hospital. We review the times. I review the clinical treatment of that patient.
We go through each case in detail, and any cases where there have been delays of any sort, we'll take the case apart and look at every step and make sure that there wasn't a problem which we need to know about and to iron out in the future, so that we can learn from every case and we can constantly be improving what we do. The high standard performance has given everybody lots of pleasure because it's a real reward for their hard work. And it's a reward because we know that we're treating our patients well. It's not because we feel we're the best in the country. It's about trying to do the best possible job for the patients that we have the responsibility for caring for. And it works really well, and we're all convinced that it makes a massive difference to people's chances of surviving heart attacks and surviving them to get back to good health. And that's what really matters to everyone.
For me as a paramedic, it feels really good. It's one of the best things that we do, that we see that is reversible, that we can treat very, very quickly. It's very gratifying, and when you see some patients who are extremely poorly, from an hour before you met them to an hour later, to see them almost instantly far, far better is a real privilege, and it's very gratifying in terms of work.
Yeah, it was all very good. I must say it was done so quickly and so smoothly that you would think nothing was going on. But, as it was, I was back in the ward. Even my wife said, "You look better now." Because I think I've been having the blockages for so long that I was really out of breath all the time. No matter what I'd done, even doing a little bit of shopping, I go back home, I sit in the chair. "What's about you?" "Oh, I'm out of breath."
The whole team was very speedy, very accurate, and marvellous. Yeah. And me being here now is proof of that.
If somebody collapses in the street or at a place of work, then the first thing to do is to call for help. So to get somebody to call the paramedics immediately. And then anything that people with training can do to support the patient until they arrive can make an enormous difference. And there is an increasing number of community responders now across our society who are not paramedics but have been trained to help patients in these circumstances and how to use defibrillators. And every minute earlier that a patient is defibrillated increases their chance of survival by 10%. So doing things as quickly as possible and getting the right people to help the patient as rapidly as can be makes an enormous difference to their chances of survival.
Time is very important in this situation. What we would like is any member of the public, whether it's themselves or for a family member, is to phone 999 immediately on the onset of central chest pain. It may be a heart attack, it may not, but without our intervention and maybe the intervention of the hospital, it can't be decided until all further tests have been carried out.